Here we go. We are starting. Our first presenter today is Amina Banda from Radboud University from Netherlands. Then again, if I mispronounce, and please excuse me because it's like a World Cup from different people. I'm not familiar with the names. Excuse my pronunciations. Amina, floor is yours.
Thank you. Thank you so much, Sona, for the kind introduction. So yeah, I'm Amina. I'm a PhD candidate at the Radboud University Medical Center in Nijmegen, the Netherlands. And today I will be presenting Understanding Decision-Making in Cancer Screening for People with an Intellectual Disability. This is a study, a part of my PhD project, where I focus on better prevention and screening of cancer among people with ID. Cancer screening is a complex process, and it involves many stakeholders. The aim of the study was to gain a deeper understanding of the key factors and interaction that influence the cancer screening for people with an intellectual disability. Due to the complexity of cancer screening, we wanted to understand not only which factors play a role for cancer screening, but also how these factors are interacted within the broader care system. To achieve this aim, we made use of a methodology, group model building. Group model building is a part of a system dynamic approach where you collaboratively involve different stakeholders with a different background, but they all have the same problem, in this case, cancer screening among people with ID. Due to conversations, they identify the factors that contribute to this problem, and then they find the interactions where they try to get a broader picture of the complex and the system in general. It helps for the shared decision-making and contributes to commitment and shared understanding. In our case, we conducted 2 group model building sessions with different stakeholders, ID physicians, general physicians, nurses, daily caregivers, family members, and a behavioral scientist, with the aim to identify the factors that play a role in cancer screening and develop a model showing how the factors are interconnected. After these 2 sessions, we also did a validated model with the same group of people, with the same background of people, but the new people with similar profiles. These are the outcomes. Unfortunately, the picture is not really clearly, but that's also not the point because it's very difficult to explain in 5 minutes what's happening here. What I wanted to emphasize is that cancer screening is truly really complex for people with ID. While we might get an invitation to cancer screening, we might read a letter, possibly discuss it with a partner or a friend, and then make the decision to participate. For people with ID, there are many more factors involved and many more barriers and process that we need to keep in mind. What we can conclude is that in practice, the focus lies on the decision-making for people with ID. The current literature really focuses on barriers that happen during participation, so consider going to screening programs, standing up for a breast cancer screening mammography, etc., etc. What we identified is that there are actually many more factors that are happening before that process. So how can somebody read the information? Is it understandable? Is the person familiar with the people who participate during screening and who help them, etc., etc. And what we also identified is that the collaboration between all the stakeholders is really important and really beneficial to improve the support and the decision-making moment for these people. Based on these findings, we expanded our research and we wanted to better understand the entire pathway from the screening invitation to making a decision. For this, we did a case study design where we included to examine whether policies on cancer screening were available in ID healthcare organizations. We explored experience of people with ID, how do they identify and experience this cancer screening, and also to explore additionally the experiences of ID healthcare professionals, how do they organize and support cancer care for these people. These are preliminary results, so I'm still in the stages of finalizing, but what we saw is that they're actually limited to no policies for cancer screening, while many of the ID physicians actually emphasize the need for guidance. And as we mentioned before in the previous study, is that the collaboration between the stakeholders is really helpful for the support for the person with ID, but also for them. This is not really visible in practice. So especially ID healthcare professionals and ID physicians want a greater involvement in cancer screening process earlier on and not only when participation already happened. Screening support, when we're looking at people with ID, varies by living arrangement, level of ID, and personal factors. As mentioned, we also did interviews with the client perspectives, and I wanted to emphasize some. I interviewed approximately 8 people, if I remember correctly, and they all stated that they think that participation is obligatory. So they all know somebody who had cancer, who had died from cancer, etc., etc. They all stated, so my mom had cancer, and that's why I wanted to participate. They also talked about anxiety about the results, which was very common, and they also so they emphasized that if they had a negative results, that they wanted to have somebody besides them to read the outcomes, because when you receive the negative results, it's often in a letter. So as stated, so yeah, you had a negative result, and did you find that nerve-wracking to read? Yes, I did. In any case, I think you should hear it, the result, from a doctor and not from a piece of paper. In conclusion, cancer screening decision-making for people with intellectual disability is influenced by many interactive factors, and our outcomes show the importance of collaboration between the different stakeholders, great involvement of intellectual disability healthcare professionals, and a clearer organization policies. Most importantly, the perspectives and experience of people with ID themselves should remain central to the screening process. And thank you for your attention.
All right, thank you. And I forgot to mention, whoever goes over 5 minutes buying a Belgian beer, just a reminder. So our next speaker is Carmen Coco from German Cancer Society, or in German, Das Krebsgesellschaft.
Yeah.
How do I? It's already.
9. I think.
Yes, thank you very much for the friendly introduction. I'm still very new to that network, so thank you very much for having me here. I will say some words on a scoping review that we conducted within the You Can Screen joint action on cancer screening for people with intellectual disabilities. And the You Can Screen joint action is a joint action co-funded by the European Commission. It spans from 2024 to 2028, so we are halfway through now, with 29 partnering countries across Europe involved. And the general objectives are to support a sustainable implementation of high-quality cancer screening and also to achieve equity in cancer prevention across the EU. And we, as a German Cancer Society, lead one task, which is called Improving Cancer Screening for People with ID within this joint action. And we conducted a scoping review with 2 major research questions. What is the current state of research on cancer screening among people with intellectual disabilities, and what are the main findings, and what approaches have been elaborated or tested to improve cancer screening for the target group. And just show you briefly our graphical abstract. We had a worldwide scope with quantitative, qualitative, and mixed method design studies included across 6 cancer entities. And we followed the JBI and PRISMA guidelines for scoping reviews when we conducted our review, and searched systematically in 3 major scientific databases and also included grey literature. And in the end, we screened more than 4,000 records and included 78 studies in our final analysis, and found, not very surprising, we heard that several times today, barriers and facilitators across all stages of the screening pathway, and also many cross-pathway factors. We found consistently lower screening uptake in people with intellectual disabilities across all cancer types, and very few interventional studies and concrete improvement strategies. And I will just show you one figure from our results part. This is a comparison of screening uptake rates from the studies which were comparable in design. And you see each study is represented by a bubble, and the color of the bubble represents the cancer entity, so blue for breast, yellow for cervical. And all the studies in this gray area show a higher uptake on cancer screening in people with intellectual disabilities, and in the red, a lower uptake compared to the general population. So there's a very clear trend of the screening rates. And I also had a slide with the barriers and facilitators in a graphical synthesis, but I skipped this due to the 5 minutes restriction. But hopefully you can have a look on them when the scoping review will be published, hopefully. As a response within You Can Screen, we are now translating materials in easy language to different national contexts, for example, Icelandic, Norwegian, and Ukrainian context. So this is one of the responses from our findings. And we also initiated last year the Turin Memorandum, which is an agreement to improve cancer screening for people with intellectual disabilities. And it was drafted in Turin during a You Can Screen meeting. And currently there are 23 signatures from 12 countries, so different experts from screening program designers, researchers, and so on. And it's still open for further signatures. And we have one core element in this memorandum, and that is an annual national inquiry among responsible health authorities on data availability, implemented measures and reasonable adjustments for people with intellectual disabilities in cancer screening. And the results from the first national inquiry from 2025 are available following this QR code, but it's also on my last slide. There were 9 countries participating, but yeah, we will repeat this every year now to just push a bit and put a bit pressure on them or on us. And yeah, these are my references, and here you have the QR codes again. Thank you very much.
Thank you, Kálya. All right. Our next speaker is Gunilla Kulla from Western Norway University of Applied Sciences from Norway.
And it's on here, yeah. That one. Mm-hmm. Okay, thank you. Yes, thank you. You can take time now, Sona, 3 minutes. Okay, yeah, that's what I tried, yes, to not do. Yes, thank you for the possibility to present this, our plan with Marianne Hedlund, the professor there on the backstage. She didn't prefer to be here in the front. And she is the professor in intellectual disability. I am the learner, so I am very grateful to learn more about this topic in this period of time that I have been participating in this network, because it was really much to learn and still learning all the time. And also about scoping reviews. I heard that scoping reviews, that is scoping reviews, but as you all, many of you know, and also these earlier presentators have shown, there are many methods also in scoping reviews. So we are still working on this forthcoming scoping review with Marianne, as I mentioned, to find out what type of scoping review this will be in the final end. And to say so, we have begun with the first screening process, and actually I have retrieved 54 studies or hits, and it was only 1 so far that we could have used. So that's where we are. And due to that, we have already have presented preliminary result is because Marianne is the expert in this field, and she knows that there are so many Norwegian language studies publication, white papers, grey literature and studies like that, that we need really to map and synthesize in this final version. So that's the, yes. So now you understand that we are really working on this. And also the background that we have in the abstract, clearly described. So there is, one could possibly expect that in Norway they like to put the goals high, like Norway is going to become the most digitalized country by 2030 in the world. So leading. Also, you should expect it from the healthcare, universal healthcare framework, that maybe you could expect that Norway could include persons with intellectual disabilities also in these prevention strategies. But as we have learned and know, there is still also much to do in Norway about this, and possibly we can help or do something with one scoping review. So we have just evidence, just exemplified by Olsen's study, where it's clearly, that's in Norwegian, that it's clearly stated that we need to work on this topic. So, as we have heard, there are also the persons in Norway with intellectual disabilities, they have faced the same challenges like in other countries. So the aim of the study is to map and synthesize recent international and Norwegian relevant research to explore structural, professional and individual factors influencing preventive cancer services for the population. And we are planning to use Axiomalis guidance framework and possibly support it with Levak's method. And because this method is clearly, at least when you look at it, I am not talking about when you are doing it, but that you have to identify the research questions and relevant studies, select studies, chart and collate the data, and summarize and report, also according to the PRISMA guidelines. We are planning to work with, began with these databases that are mentioned here, and we are fortunate to have university librarians helping us with this important work, and that's really fantastic, because I have had a lot of help with those skilled persons that you feel a little bit more safe that you, wow, 1 minute, yeah. And then we have the inclusion criteria, exclusion criteria that we should have. And like in the first hits, we really got too many studies with concerning dementia. So they were not the best inclusion criteria. So we have already worked on that too. So after this conference, we will work hard with Marianne and also take other persons that are working daily with this topic. So thank you so much. No beer.
Thank you, Gunilla. I know, once you are here, 5 minutes go so fast, right? And our next speaker is Agnieszka Sheta, sorry. University of Warmia and Mazuri in Olsztyn, Poland, or Polska. The floor is yours. Oops, I need to, sorry. And Poland is not in the World Cup, is it true?
Yes, it's...
No, we are not.
Yeah. We wish we didn't go there too. Türkiye went there, and then it was so embarrassing for us. We wish we didn't go. So Italy was smarter than us, I guess.
Hello, everybody. I would like to present to you a research project carried out by a group of university researchers, me Katarzyna Ćwirynkało, and Professor Monika Parchomiuk. We are from the University of Warmia and Mazury, and Monika is from University of Maria Curie-Skłodowska in Poland. And we did it with a group of co-researchers with intellectual disabilities concerning the experiences of preventive cancer screening among adults with intellectual disabilities. People with intellectual disabilities face an elevated risk of several diseases. We know about it. They experience persistent health inequalities in access to health care and in the uptake of preventive measures such as cancer screening. But here is the critical gap. Their own views on cancer and its prevention remain largely overlooked. This is not just an oversight, it is an injustice. As Miranda Ficker reminds us, people have the right to be heard, to be taken seriously, and to contribute to knowledge. People with intellectual disabilities are often excluded from research, a form of what Wonsir and Johnson call epistemic injustice. Inclusive research approaches, such as participatory and co-design methods, actively challenge this injustice production. And this is our group. Since 2022, after conducting training and workshops on scientific research methods, we have been collaborating with several persons with intellectual disabilities. You see one of them, it's Alicia, she is with us. Our co-researchers form the Strong Voices group, this is our name. Together we have conducted several qualitative studies using various research methods, addressing topics such as self-determination, religion, lives of people with disabilities, and health. And this is our project, Health and Cancer Prevention. We used individual interviews with people with intellectual disabilities, and we applied thematic analysis as the research analysis method. Our co-researchers participate both in the stage of preparing the interview questions, in co-conducting the interviews, and in formulating the conclusions derived from the analysis. Our study group consisted of 44 people from Ostróda and Lublin. What did we find? 4 main themes emerged. Knowledge about screening programs, attitudes, varied personal experiences, and barriers to access. The experiences themselves fell into 3 categories: positive, negative, and most strikingly, no experience at all. And let me share what participants told us. Of course, we have much more, but this is an example. First, positive experiences were rare but powerful. When screening happened, it was almost always because family members or staff at their facilities took an active role. One woman said, this is the first, my grandmother and mom were sick, so I have to take care of myself too. Every 2 years I go to the gynecologist for my breast or for the women issues. Mom told me to get checked out and to see a doctor. Another female participant described gynecologist examination in details. These positive examples are crucial. They show what works. Positive example and support of a significant person. Second, negative experiences were linked to systematic barriers, inadequate infrastructure, exam rooms not adapted, lack of appropriate equipment, no funding for reasonable adjustments. Fear was also a major barrier. Fear of the test itself, but more deeply, fear of being diagnosed with cancer. One of the barriers is also a lack of knowledge and embarrassment about certain medical examination. One woman said, "To me, it's like touching places that shouldn't be touched. I wouldn't want a doctor to touch me there. I've only been there once and I got so tense that my head started spinning." Okay? Conclusion. The key barriers we identified were informational, emotional, and structural. Despite these barriers, participants are not passive. They want to know more about what the tests are for, how to prepare, where they are conducted. They are asking for practical workshops and easy-to-read materials. And remember, co-design with people with intellectual disabilities, fund accessible infrastructure, produce easy-to-read materials, and most of all, listen, because when we listen, we save lives. Thank you very much.
Thank you, Dr. Agnieszka. And our next speaker is my good friend, Peter Knapp, Professor Peter Knapp. You know, we start talking about beer, but I owe Peter beer because Turkish team Galatasaray lost to Liverpool. And we had a bet in our last meeting, and then I lost the bet.
I thought it was 2 beers.
Sure. And
Can I put my laptop in?
sure, of course.
Can I move that?
I'll put in your chair.
Oh, no, it's fine. It's fine. I'm making, oh, so I'll do with that. So I'll do with that. So. Okay, thanks very much. And this is a piece of work that's underway, hasn't quite finished, but I thought this conference was a real opportunity to present the preliminary results. This is a piece of work that's really, the impetus for this research has come from Cupid. So it's a kind of some gratification it's a gratitude to Cupid for providing that interest. So it's about HPV vaccination in children, primarily girls, but children with intellectual disability. So cervical cancer is the second most common cancer in women worldwide. But the evidence is that 99%, almost all cervical cancer cases are associated with persistent infection with HPV. And the HPV vaccine is about 90% effective at preventing the precancerous lesions. And immunisation has been available since about 2001. Australia was the first country in the world to deliver it, and now it's been delivered in 76% of WHO countries. And the aspiration, of course, is to attain 100%. But and it's usually delivered to adolescents at the age of about 12 and 13. When it was first introduced, it was introduced to girls only with 3 doses. So some of the research I'm going to show you dates from that period. Now, in most countries, girls and boys are given a single dose. And of course, it's their consent or their parental consent whether they receive it or not. Okay, we know that many cancer outcomes are more serious, are delayed in people with ID. That's the whole premise behind Cupid. And we also know that children attending special schools tend to be less likely to receive early years immunisations where they're young. So we thought we should have a look at the data on HPV vaccination. So did a scoping review to answer 2 questions. One is, what's the rate of HPV vaccination in adolescents with intellectual disability compared to the general population? And then, are there any data on what reasons are given? What are the explanations, the barriers and facilitators, if you like, for receiving a vaccination or not? We did a scoping review. I'm not going to talk through, I think you all know what a scoping review is. I think we use good practice methods, about trying to reduce bias and to increase sensitivity in our I won't talk through this slide. What we found is 25 studies. So 25 studies between 2009 and this year. We did our search to May 2026. Australia, most of the studies come from Australia, the US and the UK, and then 5 other countries with just 1 study each. 17 studies reporting vaccination rates, and 11 of those comparing rates with the general population. Some of those just in women only, and some reporting men and women. And then there were 10 studies looking at the reasons for vaccination. So we had this 2-pronged interest in this review, and we found studies helping us to answer both those questions. And then we've been able to do a meta-analysis. So when there were enough studies providing us with data on the rates in the general population compared with girls with intellectual disability. So I wish the slide was a bit bigger. So I hope you're familiar with what a meta-analysis shows. Basically, you're most interested in this point, and so the meta-analysis pulls the studies together and provides an overall result. The bottom line is girls with intellectual disability are 27% less likely to receive HPV vaccination than girls in the general population. There's a huge amount of variations, lots of statistical heterogeneity, which will be attributable to all sorts of things about how the vaccination's delivered. Some of it's historical. There's quite a range in dates across those countries. So so even though we've got a neat statistical finding, actually there's quite a lot to unpick here. If you look at, as I said, when HPV was first introduced, girls had to have 2 courses, sometimes 3 doses in order to get full immunisation. When you look at girls who had the full course, so either 2 or 3 doses, then girls with intellectual disabilities are even less likely to complete the course. The risk ratio is 0.63, so in other words, they're 37% less likely to be fully immunised. But clearly, there's only 3 studies here, and so there's a lot of uncertainty around that. So far, there aren't enough data on boys to look at immunisation in boys with intellectual disability versus the general population, but there are a few individual studies. The 10 studies that looked at reasons for vaccination, they're really complex. So some of them are around, we don't think that our daughter is ever going to be sexually active, and so we don't think there's any need to have the vaccination. There's a lot of concern about, we think the intellectual disability might have been caused by having had a vaccination when they were much younger, and so we don't want to increase the risk. There's a really useful study, I haven't got the reference here, about school staff, school staff about the conflict between this safeguarding role, protecting adolescents against getting exposed to kind of inappropriate sexual behaviours, and then the need to allow them to have autonomy and to be sexually active if that's their choice when they're older. So that's kind of this really, for school staff who are often the gatekeepers to the immunisation, there's, the decision on their part is really difficult. And then there's something around information giving you be aware of the kind of anti-vax conspiracy theories, which have really come from COVID, I think, but are quite prominent in some parts of the world and seem to be affecting attitudes towards HPV vaccination. So it's a really interesting study, but I guess there's need for primary research. Can we do interventions to try and increase the uptake of HPV vaccination in children with intellectual disability? Thanks very much.
Thank you, Peter. And our next speaker is Neslihan Pehlivan from Hitit University, Çorum, Türkiye.
Thank you. Hello, everyone. First of all, thank you very much for this opportunity. In this conference, this invitation is very important for me. Today, I will present a short preliminary study about cancer prevention awareness among staff working with individuals with intellectual disabilities. First of all, people with intellectual disabilities may experience difficulties in accessing health information and preventive health care. Staff members play an important role in supporting awareness, health behaviors, and preventive care. However, in Turkey, there is limited research on the training needs of these staff members. Therefore, this study focused on exploring this topic. The aim of this study was explore cancer prevention awareness, health-related practice, and trainings needs among staff working with people with intellectual disabilities in Turkey. I conducted a cross-sectional preliminary survey using an online questionnaire. Participating was voluntary and anonymous. In total, 68 staff members participated in this study. Most participants were female and most participants disability care staff. Descriptive statistics were used for analyzing. In this result, many participants had limited previous training about cancer prevention. However, most participants were interested in further training. Many staff members also reported they support health checkups for people with intellectual disabilities, and the most requested training topics were healthy lifestyle, risk factors, and screening. In conclusion, staff members already support preventive health behaviors for people with intellectual disabilities. However, more structured training is needed in this area, and accessible and easy to understand communication is also important. Finally, further research with, of course, larger sample is needed. Thank you very much for listening to me. If you would like to contact me, my email address is on the slides. That's the
Thank you, Dr. Pehlivan. And our next speaker is Kálya Yasmina Lima from one of my favorite city, Dublin, Ireland, from Trinity College. Okay. I do not see mouse. Do you see it? Okay, now. All right, the floor is yours.
Thank you. Hello, everyone, again. My name is Kálya. I'm data manager at IDS Tilda, and this project was created by me, Dr. Darren McCausland, Dr. Martin McCahon, and Dr. Louise Lynch. It's named Factors Associated with Cervical and Breast Screening Attendance in Women with Intellectual Disabilities. So I think we all agreed now, after all discussion, that women with intellectual disability face many inequalities, especially when it comes to access to preventive health care service. But there is a limited evidence regarding which influence this attendance. So this study has as aim to understand, to identify whether access to technology, literacy level, social inclusion and support influence screening attendance and reasons for non-attendance. So this study is part of Wave 5 of IGS Tilda, and we included 275 eligible women for cervical screening and 254 women eligible for breast screening. So regarding cervical screening, we saw 71% of the women were invited, and from this, only 30% attended screening. Most of them were living in community group home and had mild or moderate level of intellectual disability. And what we saw, a cause of intellectual disability, especially those regarding those who reported having Down syndrome, and high self-choice scores and lower literacy difficulties were related to higher attendance. Among those who did not attend cervical screening, the main reasons were fear and lack of understanding of the exam and its importance, but also not having a recommendation from a GP or other health professional. Regarding breast screening, we have 71% invited again, but only 49% of the women attended. As before, we have most of them living in community group home and with mild or moderate level of intellectual disability. Those women with higher self-choice scores and living independently or with family were more likely to attend breast screening. On the other hand, those with severe and profound intellectual disability were less likely to attend breast screening. And the main reasons, again, we have lack of understanding of the exam and the importance, but also fear of the exam in general. So if we can summarize, we see that when women with higher self-choice score, literacy, and mild or moderate level of intellectual disability are more likely to attend breast and cervical screening. And then what we can see for this study, the personal barriers were more important than the barriers regarding this system for this study. And which highlighted the importance of making information easier and accessible for women with intellectual disability, but also the importance of the cares and the professional in general to support women's choice. Some of the reference, and thank you.
Thank you, Kálya. It was short but very informative. And our next speaker is Professor Dr. Oznur Korukcu from Akdeniz University, Antalya, Türkiye. Floor is yours.
First of all, I would like to thank the organization committee and management team, and of course François, she's not here with us, for having us here. This is really remarkable for all of us. I would like to tell you about participation in cervical cancer screening among women with intellectual disabilities, and what do we know. As we all know, the topic is very important. Understanding barriers to screening is essential for equality cancer prevention is core priority of the Cupid project. We discussed about, actually Peter told us how important HPV vaccinations is important for all boys and girls all around the world, because the cervical cancer is one of the most preventable cancer type for women. So we can handle it very easily. And we have also HPV vaccination. It is not free in our country, in Turkey, but I know that in Europe it's free for women, not only for girls. I think some countries have free in boys as well. So this is one of our strongest knowledge. And we know that the women with intellectual disabilities face major health inequalities across healthcare systems. And also they have lower uptake. Screening participation consistently lower among women with ID. And also in the morning, it was very touchable. We listened some friends, colleagues, and they state their own feelings, and they said that they had delayed diagnosis. So it's one of their problems that we must handle. The aim of this narrative literature review summarizes the current evidence, identify key barriers and facilitators, and discuss implications for inclusive cancer prevention policies and practices with intellectual disabilities women. When we search about barriers to screening participation, we know that women with ID consistently show lower screening participation rate across all countries and healthcare system. There are some problems. One of them is individual, the other is interpersonal, and the other is systematical one. Individual problems are communication difficulties, limited accessible health information, fear and anxiety about procedures. You know, this is another topic for not only the woman less ability, all of the women can fear about pap smear procedure, colposcopy, that kind of procedure. So fear is an important topic, and I work also fear of cancer. This is my special area as well. So negative past healthcare experiences, I think this is very important. There are lots of studies about this, but the experience are really important for further treatment or further prevention applications. And interpersonal barriers are insufficient caregiver support, healthcare professional attitudes, lack of disability-sensitive communication, poor coordination between care providers. And also we have some political or systematical problems, transportation access barriers, complex appointment systems. In my country, it's complex for everybody, for elder people as well. Inadequate provider training, absence of accessible information materials. So we need to do something for women with ID. For example, caregiver support, active involvement of caregivers in appointment planning and attendance is important. We also have trained professional. You know, this is something else. We need to be more sensitive, so we need to train people. I think one of the aim of this project is being awareness and trained. We are here for this, discuss and learning each other. Because we are able, we are not disabled people, so it's important to get some professional training, classes, course, and education, and also accessible materials, easy read information, and person-centered approach. This is very important for the experiences. So women with ID remain underserved in cervical cancer prevention. Multi-level interventions are essentials to improve equability access to screening service. I would like to thank you all for listening to me. This is my contact details. Thank you.
Thank you, Dr. Korukcu. Last but not least, Dr. Genevieve Breau from University of Greenwich, United Kingdom. And I also want to mention that UK is doing quite well in the World Cup. And they are, I think they are one of the key series contestants who may win this year.
Well, thanks. Well, I should just say, even though I am based in the UK now, I'm originally from Canada. So in Canada, we're happy that the Canadian team gets to play in the World Cup. So thank you very much for today's time, Genevieve Breau. I'm at the University of Greenwich in London. And today I'm going to present to you about a group I've been working with for 3 years now. So in the UK, there's this charitable network called Knapp that supports people with learning disabilities. And I have, like I said, for 3 years been working with a local Knapp group called Bexley Knapp, where I've been working with their self-advocacy group on a regular basis. And today is just a snapshot of just one of the projects we've done together. So today I'm presenting on how self-advocates with learning disabilities share their feedback on a cancer screening study with learning disability nurses. So I should say how this started was that my colleague Peter Woodward and I, also at the University of Greenwich, had conducted a series of 11 qualitative interviews with learning disability nurses across the UK on how they can support patients with learning disabilities, how they can access cancer screening. So this was more focused on breast, cervical, and bowel screening, since that's what I focused on in my prior PhD work. However, we did sometimes discuss other forms of cancer screening and prevention, such as skin cancer prevention or prostate screening, which isn't currently population-based in the UK, but is done in some cases. So as part of our larger dissemination project, so basically we wanted to look at how we could make conferences such as this, research meetings, dissemination of research findings in a way that's accessible to people with learning disabilities. So we shared the findings from this qualitative interview study with these self-advocates with learning disabilities who were part of the Respect self-advocacy group at Lima and Knapp. So basically, our objectives were to gather feedback from self-advocates on how the relevance of the study findings, how they related to their own experience and their peers with learning disabilities. So we looked at what they basically thought of this learning disability nurses, how we interviewed them to see how they support patients with accessing cancer screening. So what we did in this study, so we held an hour and a half feedback session. So that is a fairly standard time that this group will meet. They meet regularly once a week. So this was with 12 self-advocates, all of whom have learning disabilities, who form part of the local self-advocacy group. So they have been working together, I believe, close to 20 years now. Most of them are middle-aged, so they would be of the age for breast and bowel screening or approaching that age. And also what we were interested in was not just what they thought of our study findings, but what they thought, what their peers would think of the findings, and what they thought other people in their network, family, friends, even without learning disabilities, what they might think about the study findings. So I very briefly gave an overview of the study findings. And then my colleague Peter, who's a learning disability nurse by training, facilitated the discussion of the study findings. So basically, in terms of the results, the self-advocates, you could group it into three main themes, what their feedback on the study with learning disability nurses was. So sometimes, especially at first, they were seeking information from the session co-facilitator, who was a learning disability nurse himself, on cancer screening. So things such as asking what cancer screening was, why you would do that. In some cases, questions like, what's the bowel? Why is the doctor checking that? We also, sometimes they would describe their personal experience with cancer screening. So some of the women were of the age, they had attended mammograms, so they did describe their experience with that. Some people in the group were old enough, they'd received, in the UK, they send bowel screening kits by post to people now aged 50 years and up, so some explained their experience with that. And we also talked a bit about what reasonable adjustments to screening can take place as part of routine practice that might make it easier for them and their peers to access screening. For example, one suggestion, or some self-advocates informing the other, that for gynecological tests it was appropriate to ask if you wanted a female nurse or staff member to be present. So in conclusion, we concluded while our earlier study with nurses did have methodological rigor, our findings weren't necessarily relevant to the lived experience with learning disabilities. So future studies should adopt a more inclusive research approach and include co-researchers with learning disabilities at all stages of the research process to make sure study findings are relevant to their own lived experience. So alongside this study, I was doing another study which I presented on at a prior Cupid event, where we co-produced a video for people with learning disabilities about the need for and process of bowel screening. So that is an example of where from beginning to end, we work together with people with lived experience as co-researchers to produce the study outcome. So that is just my email if anyone wants to be in touch. And just finally, I'd like to thank the Lima and Knapp group and also the RTR Foundation who provided the funds to assist with data collection. Thank you very much.